So we are starting the next session, and for this session, moderator is Dr. Kishwar Ali. Ji Kishwar. Yeah.
Assalamu alaikum. My name is Dr. Kishwar, and I'm working as a vascular surgeon at CDA Hospital, Islamabad. Thank you, Dr. Zia, for allowing me to moderate this session on aortic diseases. We will have 3 state-of-the-art lectures during this session. One will be online via Zoom by Professor Waquar, and one by Dr. Sohail, and one by Dr. Omer Ehsan. I would like to request the chairs to have their seats. Dr. Jamshed Anwar, Consultant Intervention Radiologist at Shifa International Hospital. Sir, please have your seat. Professor Musaddiq Khan, sir. I would request Dr. Omer Ehsan for his presentation on EVAR and FIVAR, Shifa International Hospital, a case presentation.
And Dr. Waquar is also the chair.
And Dr. Waquar is also the chair via Zoom link.
Yeah.
Sir Waquar, are you with us? I would like to invite our first presenter, Dr. Omer Ehsan, Consultant Vascular Surgeon, Shifa International Hospital, Islamabad, for his presentation on EVAR and FIVAR, a case presentation. Sir, please.
Assalamu alaikum. Right, so I'm going to present endovascular aortic aneurysm repair, a local experience, and basically I'll show a couple of cases, especially for our trainees, so that they can get a bit of an idea of how these procedures are done. So ever since the introduction of endovascular aortic repair in 1992 by Parodi, things have exponentially increased, and now we look at aortic disease, different kind of diseases like dissection, transection, aneurysm, and rupture, and we think of how to manage them. And as has been discussed during the course of this conference, there are options of open repair and endovascular repair for all the different vascular diseases. But I have specifically put masterly inactivity on this slide because I think that is the most important thing that every vascular surgeon and every person who's treating any disease, not just aortic disease, any disease, needs to be aware of, that sometimes you do more harm by doing the procedure rather than by leaving it alone. So why endovascular versus open repair for aortic disease? There is especially, there has been proven to be benefit in perioperative mortalities, perioperative morbidity. There's difference. I would say benefit is not a right term. There's difference between perioperative mortality, morbidity, length of stay. The cost, initial cost and long-term cost also need to be looked at, and then also the long-term mortality and morbidity. And now we've got data coming from long trials, from results of 15 years or longer, which have put a different perspective on how things were seen to begin with. So to begin with, I'll just, this is just a little bit about the first case. This is the first aortic aneurysm EVA that I did at Shifa International Hospital. It was a 76-year-old male who was actually traveling from UK. And he presented with an acutely ischemic leg. On CTA, it was clear that he had a large 9-centimeter infrarenal abdominal aortic aneurysm from which he had embolized. An embolectomy was done, and then planning for EVAR was done. As it was an early case, so it took time for us to get the stent. However, he had successful deployment of stent from infrarenal aorta to iliac arteries, and you can see there was complete exclusion of the aneurysm. We had a 3-month post-EVAR scan here, but then the patient went back to UK, and he's still doing very well. He's having his regular surveillance over there without any issues. So this is a case where I can show you a little bit about the pre-op CT, the procedure itself, and then the post-op CT. So if we look at this CT scan, this is the abdominal aorta going into the visceral segment, and after the visceral segment we will see a short neck, a decent neck, and then there's a 5.5 centimeter infrarenal abdominal aortic aneurysm which finishes at bifurcation, and then you've got good iliacs going into the groins, turning into femorals. So we planned an EVAR for this patient. It was quite a standard EVAR. So the planning was quite easy as well. And this is the procedure. So the stent graft has been put into the aorta, and this is the first angiogram that's done, showing a good landing zone below the renals. Partial deployment of the stent graft with another angiogram to make sure that we deploy at the right place. This is the deployment of the top end completed, and now we've got the open contralateral limb where cannulation is done. And after cannulation, then we just twist the pigtail catheter to make sure we are within the sac, within the stent graft, not in the sac. This is the angiogram done for the iliac bifurcation, and then the contralateral limb is put in place. It is deployed and the sheath removed. So the post-op angiogram is then done to see how things are. Ballooning done beforehand just to make sure all the seal zones are properly sealed, and then an angiogram is done which shows successful exclusion of the aneurysm. There is always, or most of the time, a slight type 2 late endoleak. That's not what you're worried about. You're mostly concerned about any type 1 endoleak, type 1A or type 1B endoleaks at this time of the procedure, or any type 3. So this is the 4 weeks post-EVAR CT scan, and again, coming down, you will see the bare metal stents to start above the renals, and then you get the covered stent, and now you've got the contrast within. You've got a bit of a contrast coming from the IMA, which is a type 2 endoleak, which at 4 weeks you'll just monitor by repeated scans and monitoring the size of the sac. And if the size of the sac remains stable or is shrinking, then most probably the type 2 endoleak will settle itself as well. So just a little bit about EVAR results. So when we started the EVAR, the early time period, especially the perioperative morbidity and mortality, was significantly less, and there was a big cry that EVAR should be the treatment of choice for these patients. But as you can see, the graphs then started going in different directions. So the early benefit of EVAR over open repair was almost nullified by about 4 or 5 years' time. And especially when the 15-year results of EVAR came, then it was seen that the long-term benefit of EVAR is actually less as compared to open repair, and it is because of the repeated procedures that may need to be done after EVAR for patients with endoleaks or any other problems, as compared to open surgery, which completely excludes the aneurysm, and the higher perioperative morbidity and mortality is then nullified. So this is the second case I wanted to show. This is a juxtarenal aneurysm. We were discussing it yesterday evening in the dinner as well. I only got, so this was done in 2017. I got a message from the patient's son 2 days ago that he's unfortunately passed away. But when this patient came to me, he was, at that time, he was an 82-year-old male who was known to have a juxtarenal aneurysm for 3 to 4 years, and he had previously refused open surgery. So as I said, this was done in 2017, so he still had a decent amount of life after the procedure. So going through the CT scan, you can see that after the renals, it starts growing up, and it's a conical shaped neck, and then there is a 7-centimeter aneurysm with the iliacs, which were not looking too bad. So we planned to do a fenestrated stent for this patient. Now, fenestrated stent, I'm sure most of you are aware of, but for the trainees who are not aware of it, it's a specially custom-made stent for the patient, where you have to look at the the SMA, the renals, the celiacs of the patient, and then the device is made as per the orientation of these vessels. So this patient, we had a stent graft made with four fenestrations, and the plan was to put stents in SMA and renals. Celiac was also planned but could be avoided. So going through the procedure, this is a complex stent with so many different markers showing the orientation and the position of different orifices. The first scan basically just showed where the different the renals and the SMA were. Then you partially start opening the stent, and again another angiogram to see the renals. Then you identify the renal orifice, and this is cannulation of the left renal artery and then you've got a sheath in there. Then the cannulation of the right renal artery done. The right renal artery had stenosis in it, so that was pre-dilated, and then the sheath was passed into the renal artery. So now you've got placement of sheaths in the renal artery. The stent is now in its position, fixed in position. So you do the top end deployment so that the stent becomes fixed, and then you can carry on with stenting of the visceral vessels. So now this is the procedure where you can see balloon mounted stent being put into the renal arteries and deployed in its place. Here you can see the two stents visible, and the angiogram also showing the contrast to be going within the renal. This is basically dilatation of the stent which is within the aorta to superdilate it and to get it in its position. The next is the SMA. So this is again sheath going into so wire into the SMA and then sheath going into SMA, and then stent deployment for the SMA as well. For the celiac, this patient, we did look at the celiac, but it was a very short stump of celiac before the bifurcation, and it was decided that if we put a stent in, it can cause problems. And as the aorta was of normal diameter over there, so we decided not to put a stent in there. Then it's the completion of the procedure, which is like the EVAR that I showed you before. So it's contralateral cannulation, deployment of the ipsilateral limb, contralateral then cannulated, and then you can complete it by deploying the finding the iliac bifurcation and deploying the limbs. Measuring pigtail catheter can be useful so that you can double check the length of the stents that you need to deploy, although we are very limited because we don't have inventory sitting in our hospitals, so we have to order the stents, and we only have those available. So this is then the ipsilateral limb, and deployment of the ipsilateral limb. This is the retrieval of the sheath, and then ballooning with the Coda balloon to make sure that you seal all the overlapping zones in order to reduce the risk of having an endoleak. So this is then the first check angiogram, and unfortunately that did show us there to be an endoleak in the area of the visceral vessels. It was basically the right renal where the problem was, so the repeated ballooning was done, and we managed to achieve a seal over there as well. So this is coming from above, so we had to go through the brachial to do another ballooning of this of the right renal, and then this showed much better end angiogram. So post FEVAR CT scan of this patient, this is about 1.5 years after the procedure, and you can see the renals and the SMA both to be all to be patent. He developed a bit of a thrombus in his right iliac, for which I did recommend him anticoagulation, but he didn't take anticoagulation because of his dental procedures and this and that, but this didn't cause him any problem in the long run. And so this is just the CT afterwards. So follow-up, regular imaging is required post-EVAR, usually a CT scan in about 4 weeks' time. And if everything is okay, then at 6 months and 1 year. Things are moving on to convert to not using CT scan and using X-ray and ultrasound for follow-up. But I think we are not there at the moment because we don't have enough numbers, and there's always a risk of re-intervention. So this is just our experience of the endovascular aortic cases that we have done at Shifa. We've done 23 up till now. Most of them are thoracic, including traumatic aortic injury, dissection, aortic aneurysm, and mycotic pseudoaneurysm. For EVAR, we have done 5 standard EVARs, 1 infrarenal EVAR with embolization of internal iliac artery, and 1 fenestrated. And we have also done 3 cases of adult coarctation with balloon-mounted stents to dilate the aorta. Thank you very much.
Question sir end में कल this next presenter.
Thank you, Dr. Omer, for your nice presentation. I just want to ask what difficulty you faced in arrangement of these fenestrated or custom-made grafts.
Well, I think the most important thing is it requires quite a lot of personal effort. Unfortunately, the difficulties have not finished. In fact, they have kind of doubled after COVID. Before COVID, we started to have a decent number of stents available because of the inventory made available by Medtronic. That helped us doing cases, with Professor Kamal Yousaf and with Dr. Fahad Barlas. So we've done a few cases in Karachi as well. But unfortunately, now it is basically come back to the point where when we find a patient suitable for EVAR, then I have to then personally contact the vendors, then order the grafts. It takes time for the grafts to come in. This case which I've shown of the EVAR, that graft took us about 3 months to come in, just a standard EVAR. For the fenestrated at that time, actually it took the same amount of time, but I think now the fenestrated will be even more difficult. The problem is Medtronic is registered with DRAP. So for them to get a graft is maybe a bit easier. Cook is not directly registered with DRAP. They are basically a third party. So the problem over there is quite difficult.
I wanted to ask, has the publication of the NICE guidelines and the long-term sort of results of EVAR versus open, has that altered the practice in Pakistan? Because there is some evidence that has altered the practice in the UK. So has it altered the practice here, or?
I think as far as I'm concerned, I follow that the standards set by NICE. I follow them quite closely, and I've had patients coming to me, young, fit patients, and I've literally said to them, look, we are a center who are doing EVAR. We want to do more numbers. I know you can afford to get an EVAR done, but for you, open is a better option. So yes, if I get a young, fit patient who I think will be better off with an open repair than with an EVAR, then I will recommend the open repair to them.
Just a quick comment there. I'm Dr. Jamshed. I'm one of the intervention radiologists in Shifa. So we work very closely as a team doing EVARs, obviously. And I completely agree with you. I think there's a lot of us that are enthusiasts for endovascular, but particularly in my side of the coin. But it's very important to do what's best for the patient. And I think that's key. There's no silver bullet solution. It's not like EVAR is a solution. It's one of the instruments in your armamentarium. So what we do in Shifa is that there's 2 of us intervention radiologists who do EVAR and Dr. Omer who does EVAR. So we always discuss these cases in our multidisciplinary team meetings. We have a vascular MDT every week. Unfortunately, we don't have EVARs every week. I wish we did, but we always discuss these cases, and we try and choose look at the indications and do what's best for the patient. So you're completely right in saying that I think but they're not new now, but the latest NICE guidelines have tempered us somewhat.
And I think our other issue now is that because we don't have an inventory, therefore we are even more selective. We cannot take any risks in doing a patient. We recently had, I think a month or so ago, we recently had a patient who had a bit of a thrombus in the neck just barely about 8-9 millimeters, and we just said no, there's no way we are going to do anything with this case.
You have already answered my question.
So I mean, in the UK we would do ruptured EVARs as well, but here it's out of the question. You just don't have stuff on shelf. And I think somebody asked about fenestrated EVAR. That, I mean, anywhere in the world takes time because they're bespoke crafts, so it does take time to come. But we have some real challenges here, even for our standard EVARs.
So most of cases you are TIVAR. Do you do this all in elective? Are they present in an emergency? So how you plan for them?
I think the emergency cases we have done are the thoracic ones, not a ruptured EVAR, because EVAR obviously needs inventory. Thoracic ones, it was easier because Cook and Medtronic both had some thoracic stents on shelf. And that is where I say to everybody, I'm working in Shifa. We get very minimal trauma coming to us. And even with that minimal trauma over the last 3-4 years, we have done 8 aortic transactions. So this means that there are a lot of aortic transactions which are being missed everywhere in Pakistan. And that is where, like the discussion we were having in the morning about making guidelines or pathways, I think for every hospital, the difference that we made was the radiologist basically said had to set a protocol for the ER that, don't worry about the creatinine. Trauma patient, polytrauma patient, just do a scan, a proper scan. There's no need to do non-contrast scans, just do a contrast scan. And that's where you start picking up these cases.
One last question and then we can move on.
A very nice presentation, Omer. Just my question is just about logistics. Did you do all these EVARs and PVARs in the OR or in the angio suite?
No, we've got a good angio suite. It is not possible, especially for the FEVAR, to be done in the OR because C-arm is not a good one for this kind of procedure. We've got a good angio suite, which is a theater spec angio suite with flow, because that was assessed by JCI and they just made everything, the flow to be put in. So that's why we're lucky that it is a theater spec angio suite.
Thank you very much. Thank you very much, Omer.
Thank you, Dr. Omer Ehsan, for enlightening us and sharing your experience of EVAR and HUR with us. Our next presenter is Professor Syed Waquar Yousaf from Brighton University, UK. And he will present his experience of endovascular repair of thoracoabdominal aortic aneurysms. Over to you, Professor Waquar.
Thank you very much again. You will get tired of hearing my voice, but here I am. Right. Is it coming across? Can you see my slides?
We can see your slides. Thank you.
Right. Well, thank you very much. It might be a little bit rushed because Sia kindly asked me to talk about thoracoabdominal aorta and endovascular approach and solutions to it. So the first thing to say is that be careful. I mean, it's not a procedure. The complex aortic interventions have potential to cause a lot of harm and damage and impact the quality of life of patients. We have limited understanding of the natural history of aneurysmal disease in the aorta, whether it's abdominal or thoracic. So, when you're presented with patients who have aortic aneurysm, look at them carefully, because not all of them will die from aortic rupture. And so, you have to assess the suitability for intervention very carefully based on their life expectancy, fitness, and the complexity of the operation, etc. And clearly, any aortic intervention does not improve the physical well-being of the patient, so they don't improve the quality of life in that respect. Chronic dissections, in my observation, it's very rare to see a ruptured chronic false lumen aneurysm, and I think it's a relatively benign condition. It can cause a lot of anxiety, but by and large, very few patients in this category actually need a repair, even with an expanding false lumen down the line. And I have patients coming back to me 15, 20 years on, and they're fine. Uncomplicated type B dissection resist the temptation to do anything but best medical treatment. There are plans for an NHI-funded study in the UK to look at early intervention, whether it will be beneficial or not, but for the time being, stick to medical treatment. Don't be tempted to put a stent graft in uncomplicated type Bs. Young patients with connective tissue disorder, a different category altogether. They are clearly at very high risk of dying, premature aortic rupture-related death. Interventions are also high risk, and so they need to be treated and treated differently. The requirements is the teamwork. So you need a dedicated group of vascular, endovascular surgeons, radiologists, cardiac surgeons, anesthetist, cardiologist, intensivist, radiographer, etc. And the key is collaboration and cooperation and not competition. So you need highly skilled and committed individuals with small egos, so you can work together in the interest of patients. As Omer pointed out, he has the facility of high quality hybrid theatre, and I think that's an important requirement. We used to do these things with a mobile CR many years ago, but that's not to be encouraged. The main challenge I can see, and certainly our stock of stent grafts and wires and catheters, probably in excess of £500,000 that's lying on the shelf, and that must be a challenge that Omer alluded to earlier on about having access to these things, because once you start these operations, you often end up using multiple stent grafts in these situations, and that is a challenge, and I don't know how to address that. So for ascending aorta, endovascular options, as you all know, have been tried and presented, but for the time being, given where we are with endovascular interventions, I think you need to rely on open intervention to either debranch in some form, and also with the Thoraflex graft these days, you can create a proximal landing zone for these patients. So that's our approach at the moment for ascending and proximal arch. We're staying with open interventions to create a proximal solution and landing zone. And as an example, this is a recent case, a 78-year-old otherwise fit and well patient with 7.8 centimeter ascending aortic aneurysm and also a 5.3 centimeter proximal descending. And we thought about repairing that and placing a Thoraflex for future intervention on the descending thoracic aorta. But in fact, at her age, the likelihood of us wanting to do anything to the descending aorta was very small. So a more conservative approach with ascending open repair was followed for this lady. Patients with Turner syndrome and bicuspid valve and so on, they are again at a higher risk of aortic disruption and dissection. So this is a lady who, in her 50s, presented with a dilated ascending aorta and a saccular aneurysm just at the subclavian. And the plan was to replace that and then treat that with a stent graft. However, perioperatively, she dissected her aorta, and it was a rapidly expanding descending thoracic aorta. So we had to intervene fairly early with a stent graft. And of course, the challenge was that she had a recently implanted prosthetic aortic valve as well. And we had to use the interposition graft here as our landing zone. So going past the aortic valve can be, you have to do it very carefully, but it's better to go past into the ventricle than to force the guide wire, stiff guide wire onto the valve, but you need to do it very carefully. So these are the additional challenges in these patients, but you can get past the valve. And you can see that from a very disrupted aorta here in June 2020. Acute interventions can lead to very good remodeling. And I think that's where people are tempted to treat dissections early because you do get this good result. But again, I would admonish anyone thinking of treating uncomplicated type B dissections, you should not. Debranching can also be achieved if there is a reasonable gap between the nominate and carotid and subclavian. Then you can do a debranching in the neck as well. So this is a lady who again presented with expanding intramural hematoma. So I did a carotid, and carotid subclavian bypass for this intervention. The carotid bypass needs to be tunneled behind the pharynx and stay close to the vertebra, so you avoid any edema and pressure onto the pharynx there. A 6 millimeter Dacron graft does it well, and also these patients often require further intervention downstream. So she had an expanding visceral segment that had to be treated with a completion procedure 4 years later. For the carotid to subclavian bypass, I do it through a small supraclavicular incision. The clavicular head of sternocleidomastoid needs to be divided, scletus anterior, and you can get reasonable access here for a short interposition bypass. Look out for the phrenic nerve and other structures here. And that works very well if there is a good separation between the left carotid and the subclavian artery. So here we've almost managed to gain a full covered stent past the subclavian with a bypass. And the reason for doing the bypass is not only to maintain blood flow to the left arm. The vertebral artery provides very good collateral. You can occlude the subclavian, but we want to maintain antegrade flow into the vertebral artery because it's an important contributor to spinal cord circulation, and you want to minimize the risk of a spinal cord ischemia. So that's the indication for maintaining antegrade flow in the subclavian and vertebral artery. Fenestration can be done for subclavian as well. So here you can see we have used a fenestration for the subclavian artery. So coming from the arm to connect that. But more proximal fenestration and branching, it's being done, but it's probably still better to go with open surgery in those situations there. Chronic false lumen aneurysms, as I mentioned earlier, we are generally conservative about them, but sometimes, so this patient had a ascending repair in 2012, but the rest of the dissected aorta continued to enlarge, and he was still relatively young. So we decided to treat him, but as I said, it's a minority. So the majority of patients, particularly the hypertensives in their 60s and 70s who are getting on a bit, you can leave them alone. So here we had to go back and redo the arch with a Thoraflex. Unfortunately, he developed spinal cord ischemia even with this procedure. but made a full recovery. So I had to wait a little longer before treating the distal segment with a fenestrated component down to the iliacs. And interestingly, he has got a persistent endoleak here, which is coming along the left renal. So the dissection flaps is going into the left renal artery. We're looking from behind here, and there is persistent endoleak. And I'm a bit fearful of, you can put a stent here and then we can shut it, but there are still lumbers being perfused from this endoleak. So I have waited a little longer, and but I'll go ahead and treat this with a renal stent further on the dissected segment, and be prepared to fenestrate the stent graft with an outback catheter should a problem develop later. Now, dissections also extend into the iliac arteries, and this is a patient who had thoracic stent graft for a complicated type B dissection and a renal stent. And then years down the line, he continued to dilate the false lumen quite a lot, particularly down the right iliac. Now, the internal iliac arteries are also important contributors to spinal cord circulation. So as we're extending across the entire thoracic and abdominal aorta with fenestrated component, I had to use a branched graft for the iliac as well to maintain as much perfusion to the spinal cord, and fortunately he was fine with that. This is another complicated type B dissection with, we don't see the right renal artery here. So we treated him with a covered stent graft in this segment, a covered stent graft in the abdominal and iliac segment, an uncovered stent in the visceral segment, and a stent from the true to false lumen for the right renal artery. So complicated type B, yes, they need to be treated. This is more challenging, a type B dissection with a very large 9 centimeter common iliac dilatation, chronic, with an AV fistula, high output failure, renal failure, edema, and all that. And so we had to start at the top here with a covered stent graft, an uncovered stent across the visceral segment, and covered stent graft here. But of course, the fistula continued to perfuse along the uncovered stent, so this was followed with a covered with fenestrated component, which took about 4 weeks to be manufactured and delivered. This is a patient who had previous open type 4 repair in a reputable center in London. Khalid would know what I'm talking about. And 10 years later, he had a recurrent large 10 centimeter aneurysm at the site of open repair. So open repair is not totally immune from long-term problems. That's important to bear. And he had also lost the left kidney during that first operation. And he presented with rupture. So we didn't have the luxury of ordering a custom-made graft. We didn't have a T-branch on the shelf either, which is a off-the-shelf branched device. So I had to improvise and create fenestration in an existing thoracic graft on table to carry out this procedure. So that's also possible to modify the graft on table, but you need a lot of thought, care, and planning and experience to do that. So connective tissue disorder, that's you should have great fear and respect for these cases, and we still, debate about endovascular and open in these patients. So this was a 34-year-old man with Loeys-Dietz syndrome, and he presented with a type B dissection with rapidly expanding false lumen. The ascending was just under 3 centimeters, and there was a reasonable proximal landing zone between the subclavian and left carotid. His father had died at the age of 42 years from ascending rupture as well. So we had a long debate and discussion about treating the ascending aorta, debranching, and treating the whole thing. But it was felt that the ascending is not particularly wide, so let's treat the descending aorta first, and we can address the ascending aorta in the coming years if and when it dilates. So lo and behold, this is the first time I have experienced a retrograde dissection, but that's what happened with the stent graft. You can see the arch vessels here nicely, and this is an angiogram after deploying the stent graft. You can see the subclavian, but there's a retrograde dissection, and the arch vessels are gone. Panic and a very difficult few hours for all of us. So we had to then go in and repair that open repair, and with a Thoraflex graft docking into the pre-existing stent graft. He still needs further treatment of the rest of the descending segment and iliac segment with a custom-made fenestrated graft, and we're waiting for that to be done. Emergency ruptures, as Omer also pointed out, very gratifying, particularly in thoracic segment. A straight tube graft can save the life and solve the problem. Now, with large aneurysms, particularly large aneurysms, it's not just the dilatation, you also get elongation of the artery. And be aware of this sort of tortuosity and S-bend in the aorta. In addition, in a woman, you can have narrow arteries and they're calcified in disease. Access can be quite a challenge. So be prepared to have a wire from the arm, a through and through wire, so you can advance and pull the graft. Because if you're just pushing it, the tangential force will just take it in the opposite direction. Now, for using a branched graft, most people come from the axillary artery for cannulation of the branches. I tend to do it with a steerable guiding sheath from the femoral. Now, sometimes you have to support the sheath, and in this case, I'm using a coda balloon to stop it from riding up as we are advancing the sheath into the right renal artery. But you can also have a wire through the sheath, through and through. You can snare and to hold the sheath down in place, particularly if you use the 16 French Aptus sheath, which has got quite a wide lumen. Be prepared to stage the operations as well. So some of these operations are quite complex and take a lot of time. You don't have to finish the entire operation, and that's one of the advantages of endovascular. So here we have connected the SMA and the renal, and it was already several hours, so we allowed her to go back to HDU with a plan to come back, and you can finish off the operation later, rather than making it a very long and difficult operation. This patient had a thoracic repair in 2011, I think, with debranching, and he continued to dilate the visceral segment. But the challenge was that it's a 90-degree bend here, which again, can be very difficult to navigate with your stent graft. So again, be prepared to come from above, and that's what we had to do. So you're advancing it over a Lunderquist wire, but also pulling it from above. Otherwise, the tangential forces just push against the angle here. And that's the case where we had to do it. The spinal cord ischemia is a very serious issue with thoracic and complex endovascular repair. When you're counseling the patient, you should cite a risk of up to 20% combined stroke and spinal cord ischemia to these patients, because these are truly life-changing events, and some patients may prefer to take their chances with the aneurysm than risk paraplegia or a stroke. And have a protocol for a spinal drain in your hospital so everybody understands how to manage these patients. People are moving away from routine spinal drain, but that's with the proviso that you have the facility to put in a drain promptly should they develop a problem. And even in our hospital, we sometimes look at the rota, who is the consultant around in the evening that night. And if it's a vascular anesthetist who is around, then we are happy to be selective and put the drain if required. If we fear that it will be a delay, then we put in the spinal drain prophylactically in these patients. And of course, the extent of coverage. So in summary, select carefully. Patient selection is important. spend a lot of time planning carefully, looking at the images, looking at all the details and how you're going to approach and what challenges you might encounter, what backups you might need. Work collaboratively, building these sort of services in the early stages in any country. It's advisable to concentrate your experience on one side. You could all work together. You can, as surgeons, you can be involved in these operations. So if you have got, you shouldn't feel you are missing out on the experience. But my advice would be to concentrate in a few centers, build a good experience, and then take it beyond. But there are challenges, and I fully understand that. Be prepared to stage the procedure, and in fact, there are some advantages. So you minimize the risk of, all the problems with a long anesthetic, spinal cord perfusion, and all the rest. And get familiar with your tools. All good workmen need to be familiar with the tools they use, and same for us as endovascular surgeons. Try to stay with one type of stent graft so the entire team knows about them rather than switching and changing every case. And again, a reminder, I mean, I don't want to dampen the enthusiasm, but we have to remember that sometimes the intervention may not be in patients' best interests. And I think I'll stop here and invite any.
Yeah, there is very fantastic talk and very key messages which are given. And I ask chairs if they allow some questions to be asked for 5 minutes, 3 or 4 questions we can take. Yeah, Dr. Ehsan.
Thank you, Dr. Waquar, for a very nice presentation and quite motivating, actually. So I think shall we use our society's platform to nominate or select maybe 2 centers from country and refer all these complex aneurysms for endovascular treatment to those centers? What is the opinion of House, number one, and your opinion as well? And also, we can use this platform to actually convince the vendors to provide us the inventory maybe at a reduced rate, or maybe ask government to exempt taxes from these stent grafts. So I would like to have opinion of our senior colleagues, Dr. Waquar, and others as well. Thank you.
So if I may say something at the onset, I think, I'm really encouraged to see the collaboration that I can see in Pakistan. This is fantastic. This meeting itself, the society coming to fruition, and how you're all working together. I think that will really be important. And if you speak with one voice as a group to the government and to the companies, then it will carry a lot of weight, much more weight. And there's no reason why surgeons should not accompany their patients to these centers. You're talking about small numbers. So, if you have a patient, go with them, work together, so you get your experience as well and you're part of the procedure. And I'll be very pleased to, facilitate as best as I can with companies and so on in that respect.
I had a small question. I think you kind of answered it already about the spinal drains, but I think it's crucial because that's a unfortunate risk, having spinal cord ischemia, and especially with these kind of full metal jacket stent grafts where you're doing quite a lot of work. So how do you discern or decide where you're going to put in a prophylactic spinal drain and where you're going to kind of keep the vascular anesthetist on standby?
So if we are covering the entire aorta to the iliacs, then clearly they are in the high risk category. And in those cases, it's probably better to get a spinal drain in at the onset, so you've got it all set up and running, and there's no issue. In cases where you're just treating the thoracic aorta, for example, and not just coming across the visceral segment, then I think you can have selective approach. But with the proviso that if your hospital is able to put in a drain at 9 in the evening, when there's no delay overnight, etc. And if you fear that the manpower will not be there, then just put it in beforehand. Yeah.
And I really appreciate your comment about not necessarily finishing the procedure in one go. Sometimes you do need to stage things for a multitude of reasons. But as my radiologist hat on, I do realize that these cases, sometimes there's a lot of radiation dose. It's such a long procedure sometimes that you just kind of need to keep an eye on that side of things as well, because they can be quite long procedures.
And there is fatigue as well. Mental fatigue. We don't, because when we are in theatre, we can be there for 8 hours. We don't feel a thing. It's only when you go and sit down you realize. So I think
I remember fenestrated EVARs where you're just completely exhausted by the end of the fenestrated EVARs.
So between yourself, you should have this sort of understanding beforehand that look, we're going to reappraise the situation. Talk to the NEs, talk amongst yourself. Look, guys, we've been trying for an hour to get into this branch or whatever, and it's really proving very awkward. We haven't done any harm. It's 6 hours now. We can stop. We can come back tomorrow all fresh, and then suddenly everything falls in place. Patient is not compromised. And that's the advantage of endovascular. In open, we can't. We have to get everything done, so no matter how long it takes.
I just wanted to. I think those are wise words. What Waquar says about doing these procedures in one or two centres, because I think the problems are, you need a whole team around this. It's not just as Waquar said, the team is really important, and you need to get the volumes and you need to get the experience. And I think as has been said, is that the surgeon can always travel to the centre that's been allocated, or and it's quite painful to see other cases going to other centres that you'd like to treat locally. But actually, in terms of development of a speciality, in terms of development of experience, the good thing about it is if you do it like that, then the numbers come up, your experience comes up, you become renowned and reputable, you attract more cases, and then eventually one centre isn't enough, and then you can then spread the knowledge and the skills to other centres. So I think that comment is really, really important, and I really would take it very seriously, because in this situation where you have this field where lots of people are starting up, and the specialities, there can be lots of false starts, and there can be a lot of people who start and fail. And I think that if you can somehow get to that mindset, realizing that in a few years there'll be such a demand that one centre won't be enough. And I think the other thing is that it will also mean that the graft companies will say, okay, well, this centre is doing 50 cases, 100 cases a year. It's worth putting an inventory in there. It's worth putting stock in there. It's worth, it just becomes more financially viable for them.
Yeah.
And that benefits the country in general. I think that has to be a good way forward. So I just want to reiterate something that's already been said. Sorry to
that is very
labor
good
the point.
suggestion given by Dr. Ehsan and actually reinforced by Professor Waquar and Mr. Choksy. Probably we can work from the society forum and actually make it a pro case and also become a financially viable case that we can work.
Just one last question. I know this is an interesting discussion. So as an interventional radiologist, just one other thing that we need to start thinking about. I'm not sure. It's opening a can of worms. There's a lot of discussion that needs to be had about this. But obviously, there's a AAA screening program in the UK and in the West, in the US, all over. I don't know. I mean, I've tried to get the figures. Our data is very scant. We really don't know exactly what the disease burden here is. I suspect we have a very low life expectancy, and a lot of patients die of coronary artery disease before they develop AAAs. But I think there have been studies even in the UK that have shown that South Asian populations maybe have a lower instance of abdominal aortic aneurysms, but we don't. It's still work that needs to be done. Just something to throw out there as to, do we need to consider at some point, a screening program here, and would that help?
So, yeah, you want?
Just adding on to what Jamshed is saying, and I think what I would say that the point that has been raised by Ehsan, that Jamshed here is the representative of IRSP, and the conference is next week. So maybe these are the points which we can take to the conference next week. That the screening program and the centralization of these complex cases. So if the two societies, the Society of Vascular Surgeons and the IRSP, can come together on these points, that would be brilliant for the country.
I completely agree. I'm currently the General Secretary for the Interventional Radiology Society of Pakistan, and I was just thinking this morning. I thought that we should have ideally some platform maybe where PAKVESCON and IRSP can have a combined conference maybe moving forward.
So coming back to your screening program, we have a study published recently of our cases which has been operated for last about 3 decades. This is open surgical cases, 2 decades. And what we found that the cases which we have operated are the large aneurysm. The average size was 7.6 centimeter. And they were mostly they are symptomatic. More than 90% they were symptomatic. And they were the younger patient, means the average age was 60. So what we see that the average age in the Western countries is more than 77, and the indication for intervention is 5.5. So this does signal that we are getting patients, we are missing the patient due to lack of the screening program. We are getting patients who are more symptomatic and have more complication, definitely. And we have a younger patient who are presenting. And this does enforce that we need a national strategy to improve the risk stratification and improve the best medical therapy. So this actually points to the screening program. I may take Professor Waquar, does it has decreased the mortality in the UK or not, the screening program?
So, I mean, screening program, again, in UK, there are questions being asked about the cost effectiveness and, and quite rightly. So but I think it's very important that although we assume that aneurysm disease is less common in Asian population, etc., but it may be a different subset and category. I think, again, you need to make a concerted effort to have one population-based funded program, and you can get international funding for that in Pakistan. You have to identify an area where that's feasible, so you can get data. I mean, the screening program in the West also, it started from small studies in Western Sussex, in Chichester, in Western Australia, and, so I think it's worth pursuing that as a collaborative research project. Again, you need to agree amongst yourself that will be a national effort, but in a defined population, because unless you do that, scientifically, we cannot really say what is the, how common it is and whether patients at an earlier age get aneurysms in Asian population, etc. Because 65 years, old men for the screening program is the optimum target in UK. It may be that, the optimum age for smokers and other risk factors in Pakistan might be 55 rather than 65 even. So those things need to be thought through.
Yeah, that is good. So Professor Kamal has a comment. This will be then that really, I know this is really interesting. So we take Professor Waquar and that really,
I will ask Dr. Sufi and Dr. Tazaz as well. The things which we have observed over the time is that we have more stenotic diseases. We have aortic segments more stenosed rather than the dilated diseases. So that we should also consider that, rather than how many of us see the aortic aneurysm in a year time? Probably a couple of. So there is no point in screening on those things which are irrelevant to us at the moment. Our problem is mainly the diabetic angiopathies, stenotic disease of the aorta, carotid diseases, stenotic. We have microvascular issues mainly. We have more infrapopliteal diseases. We have more intracranial diseases. So rather than following the UK, I have worked in UK and I'm quite sure that we have the dilatation diseases mostly than the stenotic diseases. But coming here and practicing in this setup, and you can also second me that we don't have these dilatation diseases. We have mainly the aortic.
So that may be another point of view. Yeah, that is good. That is good. Dr. Elias, yeah. Dr. Waquar, sure.
Sorry, my question to Professor Waquar. Earlier, Mr. Choksy asked Dr. Omer that how did he change his practice after the NICE guideline? So I want to ask you, how have you changed your aortic practice after the recent NICE guidelines?
So we haven't, and the reason being that we always had a balanced approach to management of these patients. So younger, fit patients, a good candidate for surgery, open surgery. That's what they get. But the problem with NICE guideline was that are we talking about the initial drafts or are we talking about the final NICE guidelines? Because they're different. So the initial drafts were talking about elective endovascular surgery should not be used at all, but it should be used in emergency only. But that had to be retracted because it wasn't practical. It wasn't, you couldn't have a program for ruptured aneurysm where you're not doing any elective endovascular, for example. And also there were other considerations. So no, I think you need a balanced approach. But you still find that there are, certainly in UK, majority of patients that still get endovascular nationally on our NVR. But there were centers where doing 90% endovascular, they have adjusted to a more reasonable approach. And there were centers that were doing, so no, our practice has remained unchanged. So we still, we've always offered open repair to the younger fit patients. And there are, for surgeons, one of the consideration is the BMI. We often don't talk about it. You see somebody who's got a BMI of 35 or 40, you'll be very happy to pass them on to an endovascular team rather than do an open repair. So, I mean, things like that come into play.
You want to?
I think
Okay,
last question and then we will move.
While Dr. Kamal Yousaf was expressing his thoughts, I and Brigadier Ehsan were having a talk that on the incidence and prevalence of abdominal aortic aneurysms and thoracoabdominal aortic aneurysms. Presently, I've got 4 thoracoabdominal aortic aneurysms who are admitted in my department in DHQ Rawalpindi. And almost same is the frequency of cases that have been operated upon in CMH Rawalpindi. So I personally feel that the frequency and the incidence of abdominal aortic aneurysms and thoracic aneurysms has been underestimated in Pakistan. So I personally feel that the pattern of disease is somewhat different in different areas of Pakistan. So most of our patients, they are coming from either northern Punjab or from the KPK. But if you move down, moving towards the Sindh, I personally have felt, as we have been conducting FCPS exams there in Sindh, the incidence of stenotic disease, especially aortoiliac disease, is higher in that particular area. Whereas we have got stenotic disease primarily involving the infrainguinal vessels. So I think on the forum of this society, we should develop a central registry and exchange our data regarding the prevalence of various disease patterns in Pakistan.
Yeah, thank you.
So I think with this we should come to the end of this talk. Before we move over to the next thing, I have 2 points to make.
Yeah.
I think when we talk about aneurysmal disease and we compare our data to the West, we should remember one thing, that we have a thing called as mycotic aneurysms. We have got salmonella infection. We have got tuberculosis. And the very young, I operated many years back on an 18-year-old girl with a thoracic aneurysm. And after that operation, 2 years later, she developed full-blown tuberculosis. So I think it was associated with tuberculosis. So I think we should not forget that. That's the first thing. And the second thing, listening to all the work about endovascular and all that, I've been doing vascular surgery at times. I've been approached by College of Physicians that why don't you start a vascular surgery fellowship? And I always was very reluctant. And I said, if you don't have endovascular facilities, please don't start a program. Rather, there are times when I feel embarrassed calling myself a vascular surgeon because I'm not doing any I'm not trained in endovascular. So I think endovascular is an integral part of vascular surgery, and that should be stressed. And all the training programs should teach, train this, because it's not only an integral part. The other reason being that if they are a little slow, then they'll take over.
I think it's a collaboration. I think
Yeah.
we all work together.
Yeah, this is correct. So there's just small change in the program. We will have a 15 minute short talk by Mr. Choksy. Then we have a lunch, and then the session before lunch goes after the lunch. That is okay. Yeah.
Assalamu alaikum. Very interesting discussions on aneurysmal surgery. I'm just going to talk a short talk on complex aortic surgery, and I'm going to concentrate mainly on the abdominal aorta. So, if you look at the hostile neck, there's certain types of anatomy of the neck of the aneurysm which make it more challenging to achieve a seal for EVAR. Okay, and those are the short, straight neck, bulging neck. You've got a sort of conical neck, a tapered neck, and an angulated neck, and these are all hostile necks, which make it more difficult to get a seal, a durable seal for EVAR. Now, looking at the short necks, you can classify aneurysms in different ways, and this is one of the problems. When you talk about juxtarenal aneurysm, what do you really mean? When you talk about a suprarenal aneurysm, what do you mean? So I've looked at the classification by the European Society, and you can see that there are different classifications. There's the sort of type 4 repair. So there's a juxtarenal aneurysm, which is essentially when you have a very short neck. You have a paravisceral aneurysm, which involves the SMA. There's a pararenal aneurysm that involves the renal. So those are all classifications which are quite useful to when you're comparing results, especially, and when you're planning cases. Now, if you look at the outcome of EVAR according to neck length, you can see that if you have a short neck length, and if you have patients who are not within the IFU, this is associated with a significant risk of endo leak after EVAR. And these are the types of typical cases that have short necks. You have the native aorta. You have with no neck, for example, in this case. You have aneurysmal progression following an open repair. You have graft amalgamation after an EVAR. In this case, there's no seal. So those are all indications for considering, what can be done to treat these patients. Now, there are different therapies to treat the short or no neck aneurysm. Now, I've divided them, in my mind, into two ways you can do this. One is to extend the sealing zone above the renal arteries, okay, to an area where there's parallel neck, which is the holy grail for EVAR technology, is to have parallel neck and aorta. And that is really the gold standard. The other way is to use adjunctive devices to be able to seal the aneurysm. So you can use standard devices, but use them off-label, which isn't recommended. And we've seen the results of endo leaks after that. But then there's endo anchors that can be used to treat aneurysms with necks that are even 4 millimeters in length. And there are devices like the Alto Ovation device, which allows you to seal aneurysms that are 7 millimeters, necks. Now, I don't recommend this, by the way. It's just I'm trying to give you the full spectrum of devices that can be used in short necks, which don't involve, extending the sealing zone. When you are looking at extending the sealing zone, then there are different options. There's FEVAR, fenestrated EVAR, which has already been talked about and by Dr. Omer. and then there's the use of Chiva, and there's use of the branch devices, which you've seen, Professor Waquar talk about as well. So I'm going to say a few words about FIVA and show you just one case, and I'm going to talk a bit about Chiva as well. Now, as I've said before, this FIVA is used to achieve, but when there's an insufficient sealing zone below the renal arteries, and you're extending it above the renal arteries to a healthy portion of aorta, ideally about 1.5 to 2 centimeters in length. Now, as has been mentioned, these devices have fenestrations or holes within them to allow perfusion of the renal and visceral arteries, and then you're putting balloon expandable stents across them to achieve a seal. And then, as Dr. Omer mentioned, there's flaring of the stent against the fenestration to achieve that seal. It's used for aneurysms that are juxtarenal, pararenal, and paravisceral. Okay? So the devices that I have used in the past for this is the Cook stent, which is what we started using when we were starting the program. And incidentally, our program was started by Professor Waquar Yousaf, who took us through our very first EVAR case in 2007. So thank you for that. So there's the Cook device, which is the one that is the first device that came on the market. There's the the Anaconda device, the Terumo device, which is actually what I use mainly now. And there's a Trio device, which is a new device, which is essentially made by the same company, Terumo, or certainly sold by the same company, and that has a suprarenal fixation and an infrarenal fixation, as well as the fenestrated device. So, as has been mentioned, the most important thing about these complex cases for FIVA is the planning. There's absolutely no doubt about it. The planning is crucial, and you can't, although the planning centers and the planning technicians are fantastic, at the end of the day, when you're planning these cases, it's actually down to the physicians to sign. It's like a prescription, and it's down to you if something is wrong. So it's really important. We need minimum 1 millimeter slices and a full aorta CT right from the arch all the way down, because you may have to come from above. And you need to use software like TerraRecon, Mencia, or Osiris to plan these cases, to allow you to plan these cases properly using a workstation. So you need to be able to do accurate measurements of distances between visceral vessels and things like that, which means that you do need to have that software and ability to use that software. What happens when you send these images off to the companies is they come up with a graft plan. But as I've said, you need to check those measurements. You need to make sure that they are accurate, because I have seen cases where I've been sent some graft plans which are, in my opinion, inaccurate, and you have to check it and get someone else to check it as well, so you've got the right plan. And what they do is they send you a plan of the various of the stent, of the various angles and the lengths between the celiac and where the SMA is and where the renal is, so that you know how to plan the stent. In terms of imaging, coming down to the operating theatre itself, as I said, this cases should only be done where you've got excellent imaging, the best imaging. C-arm is not good enough for this. You need to have a hybrid theatre suite or an angio suite with theatre facilities. These are high radiation doses, so you need to be aware of that. You need to make sure you consent the patient, not just for the complications of the procedure, but also the radiation doses as well. And there are newer techniques like CT fusion technologies which allow you to reduce the dose. So when you're thinking about setting up a theatre, always think about these things, because they're available, as software to add on to your hybrid theatre. And also think about getting a completion cone beam CT scan which again, can be part of the hybrid theatre suite as well. This is just one case that we did. Majority of the cases we're doing nowadays are 4 fenestrated cases. We're hardly ever doing 3 fen cases. I think there's been a move away from 2 and 3 fen cases because the sealing zone is the most important thing, and the most the most reliable place to land a stent is in the supraceliac aorta if it's healthy. Otherwise, you have to go even higher. So nowadays, we are doing mostly 4 fenestrated cases, but this one is a 3 fen case that we did. And in terms of how we do it, it's already been gone. We've already gone through this. I think that I won't repeat that, but I think there's a few important points. Firstly, you need to get the right angles in this type of case. You need to have a radiographer who will give you the right angles, the right tilts, but you need to be able to visualize these vessels, and you need to get good views of the fenestrations themselves and how they line up, and it has to be sort of en face, we call it. So in this case, for example, where there's variety of fenestrations there. You've got one of the renal markers here, renal marker there, SMA marker, and these need to be obviously lined up with the relevant artery that you're trying to cannulate. And this, in terms of doing this procedure on the day, the placing of the main body, in other words, the fenestrated device, is the most important thing. You really, really need to get that spot on and take a lot of time to do it. People think the fenestrations and cannulating them is more sexy, but actually the most important thing is to get that device accurately placed, and it has to be spot on, and has to be deployed very slowly because the device moves as well. In terms of cannulation, I think with anything, you should always, as Waquar said, stick to the same device, stick to the same routine, don't deviate too much. Keep this, have a plan A, plan B, plan C, but always have a sort of one relied method that always works for you. For me, it's cannulating from above. Some people don't like it at all, but I always go for an auxiliary approach. You've got angulate down-facing arteries. It's much easier to get into them. So I think, that's what I do. But some people don't like doing that and do everything from below. But I often go from above. And it's easier to cannulate that. We in our center, that's what we do. In this case, you can see that there's this is the SMA. It's in the lateral view, and you can see that we've cannulated the superior mesenteric artery there. And make sure when you're doing these cases, it's very important to have someone just observing the case and make sure that the wires are not moving. You've got lots of wires in lots of places. These wires can actually do a lot of damage because they can be quite stiff wires, and if you're not careful, you could end up going through the parenchyma of the kidney and causing bleeding. So in this case, we put a floppy tipped wire into the Amplatz wire into the superior mesenteric artery. We use balloon mounted stents, which are covered stents. You can use the B graft or the atrium stent, and these are then deployed accurately with about a third of the stent inside the graft and 2/3 outside. And it's then flared after we've deployed the balloon. We flare it against the wall of the stent to get a seal. And and I think that we do this in sequential manner. The way I do it, and it varies, is I actually cannulate all the vessels first, and then I start stenting them one by one. I think it's really important to get the superior mesenteric artery cannulated first, because that's what we call the artery of death. That needs to be done first. If you're going from below, you should always stent from the top downwards, and if you're coming from above, you should stent from from the renals upwards. So it's just so that you don't disrupt the stents that you've already stented. In terms of the chimneys, I'll just say a few words about the chimney stents. This involves placing a stent parallel to the the main aortic stent, and it's a good technique for when you don't have the time to order a stent and for a FEVAR stent, and it's good for a bailout procedure. And what you have to do in this particular technique is you have to I use the Medtronic stent and the B graft again as the chimney, and you have to oversize the stent, main body stent, by 30%. They're good, as I said, for emergent situations and bailout. In terms of access, we always go from above for chimneys, and you need a kissing technique where you inflate the stent, put a balloon in the stent at the same time as you put it in the main stent as well. There's different classifications for Shifa. The most common one is the snorkel technique where you go from above, but there's other ways that you can also use chimneys as well. So in terms of comparing open and endovascular techniques, there have been lots of comparisons. There's never been a randomized controlled trial, and it doesn't look like there ever will be. But looking at these types of patients, the first thing is the comparisons can be very difficult because they're different groups of patients, often different comorbidities, surgical risk. The anatomical classification, as I've said before, may not be matched. You may be comparing a juxtarenal aneurysm to a suprarenal aneurysm. They're completely two different types of aneurysm, and you need to compare them like by like. But essentially, there's no doubt that perioperative the mortality for EVAR and FEVAR is lower according to a meta-analysis. And this is a meta-analysis that was done in 2021. At 30 months, again, FEVAR does have, is comparable then to open surgery, but EVAR done off-label is much worse. So if you are going to do a complex aneurysm, you shouldn't really be using an EVAR off-label. There's a trial at the moment that hasn't been published to my knowledge, but we have had some reports from it, which has compared in the UK the treatment of complex aneurysm using FEVAR, EVAR, and open repair, and they've graded the neck, the sort of necks anatomically as very short necks, which they've called pararenal, short necks, which they've called juxtarenal, and long necks with hostile anatomy, and they've compared open versus endovascular techniques. Now, these are the results for perioperative mortality. That's within 30 days, and there's undoubtedly an advantage for EVAR and FEVAR over open repair. You'd expect that, but when it comes to mortality, all-cause mortality over a longer time span, and this is, remember, all cases, okay, this is all the anatomical grades, you can see that there is a divergence, and open repair is better in that respect. But this is, we have to really look at the subgroups to be able to, get meaningful conclusions. So, what is the role of FEVAR in high risk and short neck aneurysms? It is good for high risk patients or in patients with neck lengths less than 5 millimeters. There's a role for FEVAR in that, but there isn't any difference when you look at longer neck lengths and look at high standard risk patients. There is a higher reintervention rate as well for FEVAR and EVAR, as you'd expect. So the ESVS guidelines, the latest guidelines that were published, this is what they recommend: is for complex aneurysms with standard risk, open or endovascular repair should be considered depending on the patient risk, anatomy, and patient preference. And I think we should take that into account as well, is what the patient wants as well, because some patients don't want an open aneurysm repair, some patients don't want an endovascular repair. So that is something that was one of the criticisms of the first draft of the NICE guidelines that was published. For high risk FEVAR or branch technology should be considered as first-line therapies for high-risk patients. And Shifa should only be considered in emergency setting or bailout. Adjunctive devices such as polymer-based devices such as I've forgotten the name of the stent now for a second, but the staples, they shouldn't be really used apart from the context of clinical trials, although they are quite widely used. So I think, just to finish with, I think that it is something that is tailored to the individual patient, and I would say that if the patient is fit for open repair and you have the expertise to repair this aneurysm, open repair is still advantageous. Thanks very much.
If the chair allows, we can take 2 or 3 questions. Yeah, Dr. Khalid Muslim.
Thank you very much. It's just a comment from what we were discussing the last after last discussion. What Waquar said was that they see more aneurysms in the northern areas as compared to what we see in Karachi or in Sindh. And I think there is some evidence to that. What I've seen, I'm working in UAE, and what I've seen in the Middle East, that majority of the aneurysms which we have seen are coming from the Levant area, Syria, Jordan, Israel area, and Egypt. And these are the areas which were occupied by the Romans and Caucasians and for a long time. And so is true for the northern areas of Pakistan, KPK, Afghanistan, and these areas. So there is some, evidence to that these areas do have some genes coming from the Caucasians, and that can be the reason of the difference between the 2 areas. Thank you.
Yeah, thank you for that.
I think, Sohail, I would like to ask that regarding the training which we are giving in Pakistan. And when people went in 80s and 90s, I went to UK in 90s, I did not find any big gap which we are working here and going there, not finding ourselves out of the place. But do you think these recent advances, this gap is getting bigger, wider?
Sorry, I don't quite understand the gap of, what do you mean?
The trainees from here, those who are going to embarking to UK or America to start their training programs.
Yeah.
So do you think we are quite behind now, but we are in 80s and 90s?
No, I don't think so. I think that, the endovascular practice is changing, quite quickly. And I think that, there is, I think that as I've said before, I think what needs to happen is that we need to probably have, in Pakistan perhaps, consider whether there should be specialist centers where a lot of the experience is concentrated for particular things. So then the trainees will get access to that, and rather than having everybody doing everything. So I think that from what I've seen, the trainees here, when they come to the UK, they're very well trained actually. They're much better than a lot of the sort of Eastern European trainees who come to the UK. They are often very skilled in open surgery certainly, and I think they pick up the endovascular skills very quickly. So I think the problem, as you've said before, is the fact that is the logistics and the fact that you can't get the stents and the economic situations that are probably more, holding things back. Because I think there's a lot of enthusiasm, a lot of expertise at the moment that people are working very hard to, acquire these skills. So I don't think there's necessarily a skills gap from what I've seen. I think that, there is a lot of stuff going on at the moment in Pakistan, and a lot of, high-end stuff that is happening. But I think it's just a matter of rationalizing it.
I think there's just one thing. very, very pertinent to Pakistan. And we all know that there's an increased reintervention rate in EVARs, and that's understood. Traditionally, follow-up has been a bit of an Achilles heel in Pakistan. I think that's something we really need to work on, because these procedures are complex, but more importantly, these patients, these cases need to be tinkered upon. You need to, occasionally close the odd type 2 endoleak and, embolize it and do things like that. So you need to keep an eye on these patients. And that's a bit of a challenge, not purely from our side, from the medical side, but our patient compliance is quite poor with follow-up. So I think we really need to educate patients before we do these procedures and make them aware in the consent process that this isn't a one-stop shop, and there's a high chance that you will need something, a minor procedure, but you'll need something else done in the future.
I think that's absolutely right. I think that there's a patient may not be able to afford all these procedures, and and if the compliance isn't there, you'll end up with patients who have ruptured aneurysms, who from ruptured EVARs. So I think that's a good point. Is that it's not just a matter of doing an EVAR and then forgetting about it. It's the follow up and the sort of regime. And I think again, if it could be concentrated, then programs could be set up to do that type of thing.
So last question from Dr. Ilyas, and then from Chair.
Just a quick question to Sohail and Waquar. What kind of access you use for the femoral? You are going for all kind of EVARs and PVARs, percutaneous, or you go for open access?
I mean, I'll say what I do, but obviously Waquar can say. So for femoral vessels, we tend to use percutaneous wherever possible. We use ProGlides. I don't know what Waquar uses, but we use ProGlides. But we choose the cases carefully, because if you've got a deep patient or a very calcified vessel, then it can be a nightmare to use percutaneous devices. In which case, we just do a cut down. We don't. But I think that if the vessel is suitable, it's a good length. It's not calcified. It's not too deep. We use percutaneous because it saves blood, it saves time, it also means the sheaths don't come out that easily. So there are some advantages, and there is some evidence perhaps that it improves the time to discharge. I think the other thing, when it comes to axillary approaches, that has to be open approach, but that's procedure that takes 45 minutes. It's very easy to do when there's
been a Cochrane review that's proven that a percutaneous EVAR takes less time, and there's no significant difference in bleeding and complications between open and percutaneous. I think it saves at least 30 minutes according to that Cochrane review. But again, cost is an issue, and like you said, I think somebody mentioned BMI, and BMI can be an issue. I think the new ProGlides can deal with slightly deeper patients, but still, do you use two ProGlides or three? Would you 10 o'clock and 2 o'clock, or how do you? And obviously, it's a pre-closure.
Use three ProGlides as a standard.
Right.
I'm sure Waquar will want to say a few words, but we use three ProGlides for each groin. But often, this is what I've observed, they often fail, and you end up having to use more, and it's very expensive. So, obviously, it has to be tailored. I think I've been to a few good centers, in Malmo and places like that, where they don't use any percutaneous. They do a technique where they just sort of do a fascial closure. It doesn't quite make sense to me, but it's a fascial closure, and they just make little cut downs.
Certainly, I've been in a situation here where a ProGlide hasn't fired or worked properly, and I've asked for another one. There's no other one on the shelf,
exactly.
So it's an issue.
I think that if there's any doubt, doing cut downs isn't a big deal, really. But I'll see what.
So on that, I would briefly say that yes, we use ProGlides, but at the end of the day, a cut down is it's neither here nor there. And I think in terms of cost, we are adding more cost to the procedure by adding ProGlides, etc. So I would. Certainly in the context of practice in Pakistan, I would feel that emergency, that's a different thing. It's the local anesthetic. ProGlide makes a big difference. You can get a graft in very quickly, but otherwise open. And the other thing I would say, and Sohail would probably agree, is that with more data coming from the Compass as well, and I was quite involved with the Compass trial as well, is that it gives you more confidence that if you can do an infrarenal clamp in anastomosis, okay, and the patient is reasonable risk, open surgery. Don't agonize about PVARs and so on in that context. It's only where you're talking about a type 4 repair or then, more complex, thoracoabdominal repairs where endovascular clearly has an advantage and benefit. So that's what I would just like to add.
That's a good point, actually, because when we talk about aneurysms, these juxtarenal aneurysms, there's such a variety of aneurysms that we're talking about. So, putting a suprarenal clamp has a different morbidity and mortality from putting an infrarenal clamp. Putting a supraceliac clamp is a very high morbidity and mortality. So I think that that's a very, very good point. That if your aneurysm extends to the visceral vessels, then and you can't repair that aneurysm's open without an infrarenal clamp, then FEVAR makes absolute sense, or a branch device.
Thank you very much. Some very excellent papers have been presented on endovascular surgery. Very interesting. And a question was asked from the audience that they see that the gap between the locally trained vascular surgeons and the people trained in Western countries, that bridge or their expertise is increasing, and I think that is a fact. And the reason for that is that we don't have that many centers that are doing these kinds of procedure, or moreover there is a question of cost. So I think I would make a request, listening to all these papers, Dr. Waquar, Dr. Sohail, that you people have a lot of experience, you have a lot of work that is going on in your center, that you should take. We only have a few training programs in this country where vascular surgery is being did, that you should become patron of one of the centers and have a collaboration where the residents are rotating through our local, say, residents from Shifa are rotating through your place for a couple of months. Similarly, residents from CMH, they are rotating through with Dr. Waquar, so that this gap that is increasing because of technological advantages that West has and we don't, that can be bridged. So, I'll be making that request. I think society or officials of the society can work out a plan like that, but that would be a big achievement in training our postgraduates in endovascular procedures. With that, I think we come to an end. I am grateful to all the people for giving, for patient listening, and all the speakers for the wonderful, excellent papers that they have presented. Thank you very much.
We meet after 45 minutes. Lunch is ready. Thank you. Thank you, Dr. Waquar. Thank you for your talk, and thank you for your precious time. Thank you. Have a nice day.
Okay, I'm going to miss the lunch and miss being with you guys. So maybe next year. Thank you.